Hi, our group will be discussing immobility as a post-op complication. The definition of immobility is the inability to move, and it could be due to a surgery, an illness, or a medication side effect can also affect the patient's mobility. It can also be one part of your body or the entire body. The concept that immobility falls under is the concept of mobility, and some of the interrelated concepts can be pain, perfusion, tissue integrity, nutrition, gas exchange, and elimination. There are some reasons that can affect patients' mobility, and in post-op patients, pain and inflammation are the most important ones. So pain, according to the International Association of the Study of Pain, they say that pain is a distressing experience associated with actual or potential tissue damage. Pain can be acute or chronic, so acute being a sudden onset related to an injury or a surgery, and a chronic pain would be more than 3 months. Pain is also classified as a nociceptive pain, which is a response to a noxious stimuli, like a tissue injury. And it also can be either somatic, so bones and muscle, or visceral, which is the internal organs. The other classification is the neuropathic pain, which is considered a pathologic one. So for example, a post-stroke pain or a diabetic neuropathy or phantom pain are some examples. And also neuropathic, it's due to nerves, spinal, or brain pain. The inflammation definition is the immunologic defense against tissue injury or an infection or an allergy. So the inflammation, the pain related to inflammation is usually due to the swelling. And that also, the swelling and the pain from the inflammation can affect the patient's mobility. All individuals are at risk for changes in mobility, regardless of their age, ethnicity, race, or socioeconomic status. But aging for sure has a big role, and also chronic diseases, tissue injury, or any trauma. In Thomas' case scenario, what we found out that it could be a risk factor for his immobility, it's definitely his tissue injury due to the surgery. Also, he complains of pain 6 out of 10 on post-op day 0. He has osteoarthritis on his right hip. He also is a bit overweight, so maybe that could also play a role. And a psychosocial component that we found was that he's a bit depressed after he found out a cancer disease. Immobility is a priority problem because the greater the extent and length of Thomas' immobility, the greater the physiological consequences to his body. Like, for example, decrease in cardiac output, DVT, orthostatic hypotension, atelectasis. He can develop a pneumonia. He can also decrease his muscle mass and atrophy. We can also see skin breakdown, constipation due to decrease of peristalsis. He can also have urinary retention or infection.
I will identify 4 priority assessments for post-operative problem for Thomas John. The goal of this assessment is to gather subjective and objective data associated to the patient's pain, for the purpose of providing appropriate intervention to manage his pain level. Furthermore, to promote healing, comfort, and prevent falls from occurring when the patient ambulates. Assessment number 1, pain assessment. A detailed pain assessment can be done using LOTARP. Furthermore, a pain scale of 0 to 10 to describe pain at rest and during movement can provide more information about patient's current pain level. If the patient is nonverbal, then use a nonverbal reporting scale. Assessment number 2, mobility. Assess the patient's mobility by checking range of motion of the bilateral upper and lower limbs, along with the strength. Also, check to see if the patient has a steady gait or if he requires any assistive device for ambulation. Assessment number 3, cardiac perfusion. During this part of the assessment, I will assess the patient's heart rate and blood pressure. In addition, circulation will be assessed by palpating the dorsalis pedis and posterior tibialis pulses. It is also important to assess the patient's CWMS of the lower limbs along with capillary refill. Lastly, the patients need to be assessed for edema, pitting or non-pitting, and signs of DVT. Assessment number 4, gas exchange. Begin by assessing the patient's respiration rate and O2 saturation. It is also important to note signs of shortness of breath and increased work of breathing. Lastly, auscultate anterior and posterior lung sound to listen for clear air entry and any indication of abnormal sounds.
Some abnormal data that we found in Thomas that relates to our concept of immobility is that he has a low respiration rate of 14 respirators per minute. So this is within the normal range of 12 to 20, however it is low considering his baseline. So this means that he has decreased ventilation, which reduces oxygen supply to tissues. Therefore, Thomas will want to remain stationary to reduce his oxygen demand. This explanation can be applied to the second finding, which is that he has a low O2 saturation level of 92% on 2-liter nasal prongs. The third finding is that he has decreased air entry to all 3 bases and wheezing is heard upon exhalation. So we know that Thomas is a smoker and he smokes 25 pack years, and cigarette smoke damages the cilia, causing inflammation and restricts the airways. So O2 supply is reduced, leading to decreased perfusion to peripheral tissues, which then can impair mobility. Thomas also has a low body temperature of 35.8 degrees Celsius, and this may lead to vasoconstriction and reduce blood flow to tissues, and then influence mobilization. Thomas may also find himself being super fatigued due to excess energy spent shivering to generate heat. He also reports 6 out of 10 pain with movement and guards his abdomen, as well as edema being found in both ankles. The fluid buildup in his ankles presses on the nociceptors, causing pain. So pain can lead to emotional suffering, depression, or anxiety, which can influence his motivation and attitudes towards mobilizing. Thomas is also reluctant to take opioids due to his fear of addiction. So this means he's not adequately managing his pain, and then he will experience pain more often. Lastly, other abnormal data that we found was that Thomas is nauseous and unable to take fluids. His mouth and mucous membranes are dry, as well as his urine output being 20 cc's per hour with a dark amber color. So these are all signs of dehydration, and dehydration, as we all know, can lead to decreased blood flow to tissues and therefore can impact his mobility. And nausea in itself will want Thomas to stay in his bed all day. And lastly, his red blood cells, hemoglobin, and hematocrit levels were found to be low, and this indicates that he is experiencing anemia due to his blood loss of the colon resection surgery. So the blood loss may cause isotonic dehydration, where again he'll be super tired and have a lack of energy to mobilize.
For our 4 priority interventions, we listed pain management, gas exchange maintenance, exercise therapy, as well as patient teaching. For pharmacological interventions, we thought of administering analgesics for his pain relief, as well as maybe opioids, depending on our assessment, and other adjunctive medication, because Thomas wouldn't want to mobilize if he's in a lot of pain, so we want to put that under control. It's also important to monitor the effectiveness of the meds that we're giving as well as side effects, and also evaluate his pain regularly. As he is post-op day 0, it's probably helpful for him if we evaluate every 1 to 2 hours. So for non-pharmacological interventions, we thought of TENS, as it is known to help with pain relief, but research also shows that it helps with muscle strengthening and it helps improve pulmonary mechanics. We could also encourage him to do some relaxation techniques such as deep breathing or distraction, as well as give him cold compress and then maybe later on hot compress for his incisional site. For our second intervention, we chose gas exchange maintenance because before we could mobilize Thomas, we want to make sure that he's breathing properly. We would want to keep him on oxygen therapy until his saturation reaches an acceptable level. We could encourage him to deep breathe and cough, as well as do breathing exercises, preferably 10 times a day. We could also elevate the head of the bed because that will make it more comfortable for him to breathe, as well as change his position, preferably every hour, as well as keep him hydrated. Our third intervention is exercise therapy, and before we could do this, we want to make sure that we monitor his BP. We want to make sure he's not hypotensive, he's not dizzy, and he can actually get up and mobilize. We also want to assess for CWMS, so that means making sure that he has sensation on his legs and he can weight bear. And then we can encourage him to also do some bed exercises such as leg raises, ankle pumps, or maybe even just squeezing a rubber ball. He can also sit at the edge of the bed and dangle his feet. So as soon as we are able to stabilize his vital signs, we need to be able to sit Thomas on a chair for early ambulation. We can also encourage him to participate in maintaining his ADLs, as well as not forgetting to put rest periods in between activities because we want him to regain that energy. Our last intervention is patient teaching. It's very important for us to teach Thomas about pain management. We can educate him around opioid addiction because he has a lot of fear around that. We could also educate him about taking his pain meds when the pain just begins rather than waiting until it gets too bad, because it's going to be harder for the meds to control that pain. We can also educate Thomas about the benefits of early ambulation in order to motivate him to get moving in the hospital. It can reduce distension, it prevents stasis of the blood and thromboembolic events, as well as it can reduce pain. We could also educate Thomas about pulmonary hygiene, which means that we tell him why it's important to deep breathe and cough, why it's important to mobilize in order to maintain gas exchange and to prevent pneumonia. And every time we do medication administration, it's important to let him know what the meds are for and why he's taking it, as well as maybe refer him or introduce him or mention smoking cessation programs. So patient teaching is very important because we want to be able to equip our patients with the knowledge to promote their own health after discharge and to also prevent more post-op complications.